Good morning, everybody, and welcome to this Wellbeing of Women webinar, one of our monthly webinar series. And this one is entitled Fibroids, Symptoms, Solutions, and How You Can Adopt Self-Advocacy. My name's Lesley Regan, and I'm a gynaecologist who's done a lot of work in fibroids in the past. I'm also the Women's Health Ambassador for England currently, and I know how much the impact of fibroids are affecting women's lives, quite frankly, disabling them on many occasions. But perhaps most importantly for this next hour, I'm the chair of Wellbeing of Women. And one of the things that we've been doing in the last year is running a campaign called Just a Period, where we want to make sure that no woman gets dismissed because it's just a period. And I often say to my team and to anybody else I'm talking to, you know, we've got to make sure that women understand that it's not normal to have painful, heavy periods or a lump appearing in their tummy. They need a diagnosis, and then they need help and solutions to manage their lives so that those symptoms don't disable them from getting on with day-to-day living. So about 2 in 3 women develop at least one fibroid at some point in their life. And these growths can cause very heavy, painful periods, as I said, and in rare circumstances, they can also complicate fertility. It's much more common in, and as we're going to hear, it's often worse for Black women who are 3 times more likely to develop a fibroid, and they're more likely to experience larger and more numerous fibroids, and perhaps most importantly, at a younger age, which is why their fertility can be compromised, and they frequently suffer very severe symptoms. So we have some very special guests here today. I'm delighted that we are welcoming here Rebecca Brown, who is an expert in, well, she's an expert in living with her fibroids, and she's very generously agreed that she will talk to us about her journey and is prepared to be asked about various issues. I know that eventually, I won't spoil her story, but I know that she had very severe symptoms for a very long time. She finally underwent some surgical procedures. She's now an executive team member at the Guidance Suite, and in her own time, she's helping other women who need support with advocating, preparing for surgery, and also attends appointments with women who need the support. And I can't emphasize how valuable that is. I often say to people when they ask me, how should I tackle this problem? When I go to the hospital to see my gynecologist, and I said, first of all, write things down. And secondly, take somebody you trust with you, just as a second pair of ears. And then we have Marianne Watters, Dr. Marianne Watters, and she's a very special lady because she is one of our clinical research fellows. And as you know, one of the main pillars of Wellbeing of Women's big reason to be is to fund research, advocacy and education into all of the things that affect women's lives across their life course. But in addition to funding the research projects, we also fund individuals like Marianne, who's younger or at an earlier stage, shall we say, than me in their training, and need the helping hand to get recognised and to develop their skills. There's no point funding research, education or advocacy if we don't have the next cadre of clinicians and advocates to take this forward in the future. So she works in the Centre for Reproductive Health at the University of Edinburgh, and she has a clinical background in obstetrics and gynaecology, but her research interest lies in improving the diagnosis of problematic menstrual bleeding. And I gather that she's going to talk to us about her PhD fellowship, which we are funding at Wellbeing, and she's exploring the use of menstrual fluid as a non-invasive tool. How fantastic that would be. Now, I know that we've got another individual, Professor Faye Ruddock, joining us, but I think she's been a little bit delayed, so I'm not going to let any of that worry us. I've introduced these ladies to you, Rebecca Brown and Dr. Marianne Watters, and when Faye is able to join us, if she is, we'll go on to talk about that. So I'm going to start, if I may, with Rebecca. And what we've asked her to do is to talk for the next 10 minutes or so about the onset of her symptoms, when she started to realise that something wasn't quite right, and how that impacted on her life, and then how, this is the critical bit, how she felt when she started interacting with the medical professionals and trying to establish a diagnosis. And then we'll perhaps pause for a moment, and then we'll move on after that to talk about treatment, not just the medical treatment, but where she obtained her support and emotional well-being, and what she would like you in the audience to know about fibroids. So that's a pretty tall order, Rebecca. So thank you for coming. Thank you for taking it on board. But now I'll just go over it again. We're going to do, first of all, onset of symptoms, impact of symptoms on your life, and what it was like dealing with people like me. Over to you.
Thank you so much, Lesley, and thank you, women of well-being of women. I'm so nervous right now. I can talk forever about this subject. I'm so passionate about it, but I will try and keep it precise. So how my journey started was I started my periods at around 12, 13. And I do remember them being, I thought they were moderate, but I do remember using a hot water bottle and going through quite a few pads. But unlike other ladies that I support, I didn't remember like fainting or anything or having anemia, anything like that. So I wouldn't say my childhood period was that bad, but as I said, I did used to have to use a hot water bottle and painkillers at times. And then as I progressed into my 20s, I went on to contraception. I was on the pill and I was on the 21-day pill. And it's really important as well to mention this, but with the support group that I work with the guidance suite, we do have a lot of discussions about contraception and how that plays a part. And we almost played God in the sense that we would be on the pill, and if we're going on holiday, we'd take a pause and then we'd carry on taking it for the 28 days, even though we meant to take a break for 21 days, not knowing that this could be affecting things. And this is really crucial for us to understand why young children need to be educated, young girls in schools, because if we were educated at a younger age, we may not have been trying to do all these things with contraception, or if we were on contraception for a long period of time, we would maybe go to the doctors and actually ask, could you just do a check for us? I was 44 years old when I found out that I had fibroids, and what I've learned in that time, in the last just under 2 years, I really should have known from when I was younger, and many women will say this. So what happened, I was on the pill, and then I went to a different sexual health clinic just to, get a new set of pills. And they looked at my family history, and because my dad had a stroke at a young age, they said you shouldn't have really been on this pill, the combined pill, because of high risk of blood clots. So again, I felt really disheartened that I'd been in it for a long time and nobody had picked this up. It's just because I went to a different sexual health clinic. And then they offered me the coil, and that was what I felt most comfortable taking, because I wouldn't have to worry about missing my pill and things like that. And I wasn't comfortable with the other options that were offered to me. I had the copper coil, and it's really important to mention that there is a difference between coils. There's a marina coil and there's also a copper coil. I opted for the copper coil and was offered the copper coil because it lasts for 10 years. And for me, I was like, great, I won't have to worry about taking the pill for 10 years or missing it. I was told that it could cause an onset of heavy periods. It can also stop your periods. What I didn't like about one of the pills I was on prior was that it would stop my periods, and I did not like I did not like that at all. And that's another reason why I asked to change contraception. My periods didn't stop. I had them regularly every month. I had the coiling for 8 years before I found out that I had fibroids. So I had heavier periods that they progressed over the time of, I would say, the last 5 to 7 years. So maybe a year on into me having the coil, they started to get heavier and heavier. I was putting towels on my bed because I was leaking through, wearing leggings to bed or cycling shorts. I noticed that I started buying different sanitary products. So I started getting the Tena Lady ones that you use for incontinence and doubling and tripling those up. When I look back and I think, why did I not think there was anything wrong? Again, there's a lack of education. My friends that also suffered from heavy periods, we would all just say, oh, periods are pain. Oh, really? You wearing pads? I wear heavy pads too. And this is why it's so important, the well-being of women, period symptom tracker. It's so important because if this was available when I was younger, we would have known that something's not quite right. And there's so many women that just don't understand. We just are told that a period is normal, a heavy period is normal. And I also thought it was the onset of being on the coil. I was at work one day and I had really heavy bleeding. And again, I wasn't alarmed by this. And then my pain started. I was working from home, I'm a graphic designer, and I was a very demanding job. I was working from home and I felt a pinch. And the best way I can describe it is it was in the area where you would have a smear. You get that pinch. Ladies will know listening to this. And it was in that area. And I was always conscious that I had the coil in. And I was always conscious that I heard stories that it could get dislodged or you could have ectopic pregnancies. And I'd never had pain before like that. The pain started radiating down the top of my legs and I felt really nauseous. I took the day off sick and the next day I felt really bad. I went to the GP and they could only fit me in with a student nurse. I was hysterical. I knew something wasn't right. She laid me on the bed and she said, let me just have a look. And I said, I think it's my coil. I think it's my coil. She couldn't see my coil wires. I was totally hysteric at this point. I said, what do you mean you can't see my coil wires? And every time I'd have a smear test, I would ask them, can you check for my coil wires? Because you are meant to check for your wires yourself, but I didn't feel comfortable. So I'd always check when I had a smear test. So when she said they weren't visible, I panicked and I said, something's not right, something's not right. She said, oh, they may have broken off. Maybe they've curled it. I said, no. She said, maybe your coil's dropped out. I said, no. I had to go to the sexual health clinic because the GP do not have the scans available to be able to see if your coil is as dislodged. I went to the sexual health clinic and that's when everything just turned upside down for me. They went through a number of questions and they thought I had a UTI. They laid me on the bed and they examined me and they used the scanner. And what I thought was I was just going to get the coil removed from them. They said there's a big black mass on the screen. We cannot see your ovaries. They called another doctor into the room and they were talking amongst themselves and they were totally confused. I was obviously scared, laying on that bed thinking, what is going on? A black mass. Nobody likes to hear that term. They ran 2 pregnancy tests on me. They asked me a number of questions and they said, do you mind us giving you a hand examination? And I've never had children. So this was, again, a lot for me to go through. She gave me a hand examination and she explained to me that, Rebecca, your uterus is the size of a 6-month pregnancy. I didn't understand what she meant about an enlarged uterus. Again, at 44 years old, why did I not know what an enlarged uterus meant? I only knew that from a pregnancy. She explained to me and pointed to my womb area and said, your womb should be around this area. It's stretched up to, and she pointed to underneath my bra. I was so shocked and confused. She said, I think it may be fibroids. Dawn Hills, an amazing fibroid advocate and campaigner, is a close friend of mine. And a year prior to that, I'd been supporting her on her journey and supporting other women and putting comments saying, sending love out to fibroid warriors. I called her immediately and said, they think it might be fibroids. Dawn said, can't be that. You've been living your best life. You just came back from holiday. You don't have pain on your periods, do you? I said, no. I said, they're just very, very heavy. So I'd been watching Dawn's page and following everything, and it was staring in my face, all of these symptoms, but I just thought heavy periods were just normal. And this is why I really want every woman that is watching this that hasn't been checked, please get checked, because it isn't always normal. I didn't have pain. You don't have to have every single symptom to have fibroids. I'm not sure if I'm going on too long, Lesley, if I need to speed.
That's lovely. And I'm going to just stop you there, just because that's really good. You need to take a breath. Thank you for sharing all that. It's quite stressful for you, reliving it all. But I want to pick up on that point you made, which is so important, that if only you'd had the period symptom checker available, that you would have known much earlier. Now, I just want to make sure that everyone in our audience knows what this is. So if you go onto the Wellbeing of Women website and you just check for periods, you will come to the period symptom checker. And it's a very simple, very straightforward, clearly written questionnaire that asks women about 14, 15 questions about their periods. And then when you come to the end of the questions, they ask you if you'd like to receive a note about this to summarize what's probably the problem. And then if you say yes, then you put in your email address, and about 5-10 minutes later, hey presto, magic sends you a letter addressed to your healthcare professional summarizing everything. And I want to emphasize how important that is. It is completely free to access. You just go onto the wellbeingofwomen.org.uk website and you can access the period symptom checker, and you can generate a letter. Either you can put it on your phone or you can print it off and you can take it along to see your healthcare professional. And there you've already started, got halfway to the diagnosis because it's itemized all the symptoms. Now, when we started this, we launched this wonderful symptom checker in Parliament, in fact, in February of this year. And every time I talk to the Wellbeing of Women team, more and more and more thousands of women seem to have accessed it. So it's had enormous catch-on. So I'm delighted about that. But I think for anybody who's having problems here, not sure whether this is meant to be normal or abnormal, go on to the period symptom checker on the Wellbeing of Women website, go through the quick questionnaire and then generate a summary of the problems. And you'll find that your healthcare professionals, far from being annoyed that you're telling them all of these things on a single sheet of paper, are absolutely thrilled that they don't have to think about all the questions they need to be asking you. And it's got them to be halfway to the diagnosis and then, of course, to the treatment options. So thank you again, Rebecca. I think that was really impressive. And I'm going to turn now to Marianne, and she's going to tell us a little bit about what a fibroid is and what symptoms she thinks that women should look out for, how we go about diagnosing them, how do we treat them, and then she's going to tell us a bit. Well, we'll save your research project till a bit later because you've already got a lot to get through now, how you're going to diagnose them, how you're going to treat them. So over to you, Marianne.
Thank you so much. It's really great to be here. And thank you especially to Rebecca there for sharing your journey. I know it's really difficult sometimes to go through all of that. So I'm just going to quickly share, I've got a presentation to help share a lot of this information that we need to get through. So I'm just going to bring that up now.
Great, we can see that.
So great, thank you so much. I'm just going to launch straight into things because there's so much information to cover and I want to leave plenty of time for questions. So first of all, what are fibroids? Well, fibroids are when there is a non-cancerous overgrowth in the smooth muscle layer which goes around the whole uterus. And I've shown that on this diagram here, these kind of yellow structures in that muscle wall of the uterus. What I'm going to share next is a picture of how fibroids look in real life. And this has been taken at a surgical operation, at a hysterectomy. So please do look away just for the next few seconds if that's something that you're not comfortable looking at. But I'm just going to share that now. So this can be quite shocking for people to see, but I think it's really important to have an idea of how some fibroids can look in real life. And this is a patient who's having an open hysterectomy, so complete removal of the uterus. And I've labeled here these two structures at the top of the uterus are the fibroids. And these, just to give a bit of context on size, these fibroids are both around 5 centimeters. I'm going to remove that picture again so people can look back if they're more comfortable to do so. And I'm also just going to share this diagram here. So in this diagram, we have the uterus shown in light brown. And then the yellow circles with all the numbers are just to show that fibroids can be in lots of different locations throughout the uterus. And they can be lots of different sizes as well. And some people might have one fibroid, other people might have multiple, and they might be found in different locations. And I think it's also really important to have an awareness of the different locations because the different site of the fibroids can cause different symptoms, and they can also respond differently to different treatment options. So those on this diagram here that are numbered 0, 1, and 2, they come into the inner part of the uterus, and we call those submucosal fibroids. And then those numbered 2 to 5 are sitting right within that muscle layer, and we call those intramural. And then the ones towards the outside, like 6, 7, and 8, we call those subserosal. So I think it's just important to have an awareness of that information, and that's something that people might want to ask about if they're going through the process of finding out about having fibroids and understanding where they're located. So what are the symptoms of fibroids? Well, Rebecca's already shared her experience of this, and I think it's really important for everyone to be aware that it's a very individual experience. And Rebecca's already said that, you know, sometimes the only symptom that people have is that they have heavy periods. Other times people have normal bleeding, but they have pain. So I'm just going to run through some of the symptoms. So the really common symptom that a lot of people experience is heavy periods. And that's things like, bleeding through onto clothes or having to get up in the night to change bed sheets due to bleeding or passing clots. And over time, that heavy bleeding can lead to iron deficiency or anemia. And that brings its own set of symptoms. So feeling really exhausted, having shortness of breath or palpitations, that can all be due to iron deficiency. And heavy periods are a really common cause of that. Some people do experience pelvic pain from fibroids. And another really common thing that people report in the clinic when they come to see us at the hospital is a feeling of kind of bloating or fullness or pressure in the lower part of their abdomen. And that's because if you think about that surgical image that I showed, the fibroids can grow to quite a big size and they can put pressure on other structures. Another thing that people can experience is the fibroids can sometimes press down onto the bladder. So the bladder is really closely related to where the uterus is. And when those fibroids press on the bladder, it can cause people sometimes to feel that they need to pass urine really frequently, or sometimes they're struggling to empty their bladder because the fibroids are pressing down. In a similar way, some people might experience issues with constipation, with the fibroids pressing back onto the bowels, or an increased urge to open their bowels. And in some people as well with fibroids, they might experience difficulties conceiving or have an increased risk of miscarriage. How do we actually go about diagnosing fibroids? As Rebecca mentioned, unfortunately for a lot of people, they can experience really long delays in getting a diagnosis. The first port of call, I would say, would be to go to a GP and discuss the symptoms that you're experiencing. And then what might happen at that appointment is an examination. Rebecca mentioned an internal examination where the sort of size of the fibroids and the uterus are felt. But the really key kind of important thing that needs to happen to get a diagnosis of fibroids is an ultrasound scan. And that's something that can normally be arranged by a GP. I also want to flag again, here, we've already talked about it, but if anyone's unsure about how they go about discussing their symptoms with their GP, then the period symptom checker tool on the Wellbeing of Women website is a great resource. You can fill that out and then take that information along to your GP appointment. So in some women who are identified as having larger fibroids, so over 3 centimetres, or they're struggling with their symptoms, they'll be referred on to a hospital appointment with a gynaecology doctor. So what happens at that appointment? Well, that's another opportunity to discuss symptoms. It's quite likely that they'll repeat an examination to have a feel of the size of the uterus and the fibroids, and then there should be time to look at any previous scans that have been done, and then probably most importantly, to discuss treatment options and make a plan going forward. So moving on to think about treatment options, I just want to flag first of all that it is completely valid to do nothing. So fibroids, as we've heard already, are very common, and some people actually don't have any symptoms at all from their fibroids, and they find out just because they've gone for a scan for another reason. And if you're in that category, then that's absolutely fine. You don't need to have any treatment, but it's just, having an awareness that if symptoms do develop, then definitely discuss treatment options by going back to your GP. Then it's important to think about what is the kind of main symptom that someone's experiencing? Is it bleeding or pain or pressure from fibroids, or is it actually both? Because different treatments target those things in different ways. Also really good to think about future fertility plans, because some of the treatments that we offer people for fibroids mean that unfortunately you wouldn't be able to get pregnant in the future. And then finally, I think it's just so good to have an awareness that different treatment options work for different people, and it's really important to think about how they might fit into your lifestyle and your preferences. There is also a bit of evidence out there that fibroids, the risk of fibroids increases with obesity or vitamin D deficiency. So I think it's always a good idea, just for health in general, to maintain a good weight with a balanced diet and lots of exercise and have good vitamin D levels. Now I'm just going to go in to talk about some of the treatment options that might be offered either by a GP or by the hospital gynaecologists. The way that we sort of separate these and categorize these is to think, first of all, about medical treatments. So medical treatments really are things like tablets or injections that don't involve any surgery. So medical treatments that might help to reduce bleeding in some people. You can take tablets during your period called tranexamic acid, which have been shown to reduce blood loss in some people with heavy periods. And again, medications like ibuprofen during your period in some people do help to reduce the amount of blood that's lost. In a similar way, some people might benefit from taking progesterone tablets or thinking about having a progesterone coil. So Rebecca mentioned that already, that's the Mirena coil. That works for some people with heavy bleeding due to fibroids, but not everyone. And it tends to be people that maybe have smaller fibroids. Another type of medical treatment will help to actually reduce or shrink down the size of the fibroids or the uterus, as well as reducing bleeding. And examples of those are things that are hormone-reducing tablets or hormone-reducing injections. And they lower the levels of estrogen and progesterone in the body, and over time, that leads the fibroids to shrink down. So that's all the medical treatments. I'm now going to move on to talk about what we call radiological and surgical treatments. So just going through these, and I want to leave plenty of time for people to ask questions about these because I know it's quite a lot to get through. So things that will reduce the size of the fibroids and reduce bleeding. So first of all, some people might want to consider a procedure called uterine artery embolization. And what that means is that a scan is done and then radiologists can track the blood supply to the fibroid and block that off to reduce it down. Another procedure that can remove the fibroids surgically is what we call a myomectomy. So that essentially means that the fibroids are scooped out, but the uterus is left behind. And that can either be done as an open procedure with a bigger cut across the tummy, as a keyhole procedure with small cuts, or even what we call a hysteroscopic approach. So what that means is using a device that goes through the vagina, into the cervix, into the inner part of the uterus to potentially remove some fibroids in that way. Ultrasound-guided radiofrequency ablation and MRI-guided ultrasound treatment are treatment options that are not currently widely available in the UK. And that's because some of these treatments haven't gone through large randomized control trials to assess how effective they are. But in some places they are offered and they can work to shrink down the fibroids through radiofrequency ablation or through ultrasound. And I've also added here another type of treatment that won't actually reduce the fibroids or remove them, but endometrial ablation is a surgical treatment for people with heavy bleeding. It's done by inserting a device through the cervix into the uterus, and it can actually burn away the lining of the uterus, which can help to reduce heavy bleeding in a lot of people. That's suitable maybe for some people with particular types of fibroids. The other thing to consider for some people is a sort of more definitive option, which would involve completely removing the fibroids and stopping any bleeding, and that would be by having a hysterectomy procedure. So that's completely removing the uterus. And again, that can either be done open, that tends to be when the fibroids are quite large, or as a keyhole procedure. And I also just want to flag that it's absolutely possible to remove the uterus but to leave the ovaries behind, because the ovaries have their own blood supply and their own ligaments in the pelvis, which means we can leave them behind, and that will still allow people to have all their hormones even after the uterus is removed. And obviously, removing the uterus will then completely remove all of the fibroids, and that will be a definitive option. So I'm just going to leave things there because I was going to go on to talk about the research, but I think we'll come back to that, and I'll hand back over to Lesley.
Lovely. Well, Marianne, that was a very comprehensive, whistle-stop tour through so many things. Thank you very much indeed. And what I'd like to do now for a few moments is just to tease out some of the things or some of the misconceptions about treatment. So Rebecca very sensibly said, well, she was given this copper coil. And now she knows, of course, that copper coils are probably one of the worst things that she could do for her painful, heavy periods, because copper coils, which at one time in life, I can remember, were the only things available, but now we have a Mirena coil or a Kylena or a Jades, i.e. a coil that's got progesterone hormone in it, which actually does the opposite. Now, if I had £1 for every time a woman says to me, oh no, I don't want a coil because they they cause painful heavy bleeding. And I say, but not this coil. This coil is going to stop your painful heavy bleeding. I'd be a very rich woman, as we know I'm not. So it's really important to remember, first of all, when we're talking about coils, we're talking about the medicated coil, because that's really going to help. And for many women, that can actually transform their lives without anything more than having the Mirena device inserted either under local anaesthetic in the clinic or under a brief or a short general anaesthetic in the day surgery centre. So it's very, very simple, very, very problem-free. And we also need to remind them, don't we, that they shouldn't expect it to work immediately, because the womb lining has got to get used to the progesterone, and the progesterone needs a couple of months to get that womb lining under control. I often say the endometrial lining or the womb lining has no brain of its own. It can just respond to the hormones it's shown. So if there's lots of hormones going around, or there's something irritating the cavity like the copper coil, it's going to bleed more. When we put the Mirena in, the progesterone is gradually going to make the womb lining dampen down. And because it also has a relaxing effect on tissues, it can often help with pain. And then I was very pleased that you mentioned some of the ultrasound guided and MRI guided minimally invasive treatments. But before everybody goes racing onto their internet to find a place that does it, I just want to remind you that what we found, because I was one of the pioneers in this, what we found is that they may be helpful for women who've got relatively small fibroids or smallish fibroids, who've got a lot of pain and bleeding. So shrinking those with these techniques can be very helpful. But if you've got very big fibroids, or if you've got pressure symptoms on either your bladder or your bowel, or like poor Rebecca had, a great big lump in her tummy, it's completely unrealistic to expect the focused ultrasound to be helpful. And I say that not to be a damp squib for any of you who had their hopes raised, but what I don't want to do is to raise false expectations. So given that little bit of an intro, perhaps I'll come back to Marianne and then to Rebecca to just give them, add on to my sort of bon mots, if you like, about what the treatments can't do and how we need to get women to understand what's reasonable to expect. Not because I can't be bothered to talk to them, but because I don't want them to spend time, chasing treatments that are just not going to be helpful for them. So, Rebecca, tell me what you were told about things and whether you were offered any of these other options.
So like you rightly said, Lesley, because my fibroids were so large, and one thing I really want to mention is that many women they are asymptomatic. And Marianne, your presentation was amazing, absolutely amazing. How you managed to cover everything in such a short space of time, and it was so clear. So I was asymptomatic because my fibroids had a rapid growth. So I had to end up going to see a private consultant because I was told by my GP that the waiting time was 10 months just to see a gynaecologist to get my coil removed. So I had to take matters into my own hands, and this is where Dawn and the guidance suite came into a massive role in me advocating. And that was the best decision I made. When I saw the private consultant, they scanned me and they saw that I had very large rapid growth. And they told me that I had a 5% risk of them being cancerous. And this is, again, something that isn't mentioned. And this is something that I do want to, make women aware that there is a 1 in 1,000 chance. So it's a very low risk. But myself, I've had friends that have had to go on the cancer pathway, and I've been put on the cancer pathway 3 times in the space of 8 months. And because of the rapid growth, I was unable to have, a normal treatment because they were just so big. So I found out when it was too late. The largest fibroid I had was 12 by 10 centimeters, 10 by 10, 9 by 9. And this, again, is why it's so important not to think that if you've got fibroids, you're going to have pain or it's going to be obvious. My stomach only started to bloat up and get really hard once I was diagnosed. Ironically, I just thought I was putting on weight. And so I was offered open myomectomy because of the sizes. But as Marianne rightly said, and this is why it's so important, again, I've seen some comments of people mentioning about having children, what can they do? Very important to get your child checked, your daughter checked at an early stage. because there are less invasive treatments, like what Marianne mentioned. So for myself, I have had fibroids recur since surgery within 3 months. And so I'm on a mission to advocate for myself, make sure I get regular checkups and do all I can holistically, as well as getting medical help, so that they don't get to that large stage again. So with my case, it was too late. So I was offered the open myomectomy or a hysterectomy. I was diagnosed in April and had my open myomectomy in September, really, really fast, because I was put on the cancer pathway. So everything happened really fast for me, total roller coaster. And I didn't really have time to digest whether I wanted a hysterectomy, but I knew I wanted to keep my womb. I'd only just found out that I was compromising not to have it. So I don't regret that decision of having an open myomectomy. And I'm not sure if Lesley wants me to mention how many were found. I've seen quite a few ladies in the comments mention about scans and how scans don't always show how many fibroids are there. And this is, again, very important when you advocate and go to the doctors and they say, oh, you've only got 2. I was dismissed at A&E and told, oh, you just got 1, you just got 2. And if I'd listened to them and I hadn't got a second opinion, I really don't want to think about where I would have been now. Knowing that my fibroids were that large. On the day of surgery, my MRI showed I had 5 large fibroids. It's very common for fibroids to have clusters and to grow behind the large ones. So even if you have a scan and you're told you've just got 2, please don't automatically think that is the case. And this is why, if you're having symptoms, you do have to press on and just, you know, advocate for yourself. On the day of surgery, I was told I had 5. And I was told there may be a few more. I thought, okay, 10 or 12. When I came through, the surgeon came and told me it was a success. You lost 800 milliliters of blood. You were just shy of having a blood transfusion. And I removed 5 times the amount. And he was also so shocked. So 25 fibroids, and they were ranging from the size of 2 centimeters up to 12 by 10. So I had to open myomectomy, a vertical cut incision.
Thank you, Rebecca. And I often meet women in the clinic who are very upset if I say, well, I think we're going to have to perform a vertical incision. And it's not because I want them to have a bigger scar, it's because I want them to be safe.
Sorry, Lesley, I had a horizontal. I didn't have a vertical, but I was told I may have to because they were quite high up.
So we can try, but then, you know, sometimes you do have to for access, and it's really to save you or to protect you rather than having to go straight to hysterectomy. So, Marianne, any other thoughts that you'd like to add on the choices of treatments and some of the misconceptions that people have? Because I've spent so much time talking to women who've travelled a very long way to come to see me at this hospital, believing that we can wave a magic wand and sort it all out. And then I think I also worry about women who are travelling a long way from home in order to have major surgery, and then they've got no support around them as well.
Yeah, absolutely. I mean, I think the difficult thing about fibroids that has come out so clearly from the discussions that we've been having is that different treatment options work for different people, and it's so individual based on the symptoms that you're having, where the fibroids are, the size of the fibroids. And so it's really, it's really good to go through all the different options, but I really want to caveat that and say, you really need to think about you as an individual and kind of speaking to a gynecologist about what options will work best for you and being realistic about that, because it would be so great if there was a treatment that was minimally invasive and had really good success that could work for lots of people. But I think it's so important to just be realistic about that and to choose treatments which have a proven track record of being effective for the type of fibroid and the type of symptoms that you have. And I also just kind of want to pick up on some of the things that Rebecca was saying as well. And, we do hear a lot of people saying this, that they weren't found to have all the different fibroids that were then discovered at surgery, and can be difficult sometimes to pick up all of that really detailed information just by a scan. But even if you're told that you have just one fibroid, there's people who have just one small fibroid, but maybe it's sitting in the inner part of the uterus and it's causing them extremely heavy bleeding, losing hundreds of milliliters of blood a month from that. So, it's also important to recognize that it's not just about number, it's also about the symptoms that you're having and the different location as well.
Yeah, thank you very much indeed. Rebecca, I wonder if I can ask you, because I don't think Faye is going to be able to join us, and she was going to talk a little bit about how we advocate for Black women's health. Do you have any thoughts that you'd like to share with the audience?
I have a lot of thoughts, Lesley.
Just a few very select ones for now.
So there is sort of like a bit of a stigma, are we treated differently? There's no way of actually knowing that it's, a reason why somebody, like a gynecologist or consultant is dismissing us, because there are women that are dismissed that aren't of, an ethnic minority. But what is quite crushing for us is that it is a high stat for Black women. It's known to be more aggressive a lot of the time as well. And why there's a lack of research, I know Marianne's going to speak about this later, that is something that is very disheartening. Why there's a lack of awareness. I know now social media is amazing, and Wellbeing of Women, what you do is just incredible. So thank you. But there needs to be more of this. There needs to be more research. There needs to be more awareness, as education in schools. And yeah, I just feel that it's just very, very disheartening and very frustrating that you can go into a doctor's surgery and they can say, oh, it's common in Black women. And that word common, it really needs they really need to rethink that, medical professionals, because I was told when I went to A&E, oh, you've probably had this all of your life. And I said, respectfully, doctor, I cannot walk right now, and I've never been in this pain in all of my life. And he just dismissed me immediately and said, oh, fibroids are common. We'll get the coil out and we'll put another Mirena coil in. So that attitude, again, there's no way that we can actually say, that particular consultant is, treating us differently because of the rate. We can't know that for sure. But what we do know is, if we look at the history and look at the stats, why is there not more awareness? Why are we being dismissed? Why is it taking so long for us to have treatments? It's more aggressive in our race. So, there's so many unanswered questions.
Thank you. Marianne, I'm just going to turn to some of the questions and then give you a few moments to think about what you'd like to share with us towards the end about your research. So there are several questions here about diet and whether diet can improve the growth of fibroids or reduce the bleeding. I mean, I think there's very different views about this, but perhaps we can get your views because you've become a bit expert in this field.
Yeah, so it's a topic that people are really keen to discuss. And one of the things, when patients come to clinic is people want to know, what can I do myself? What things can I change in my lifestyle that might improve things, as well as thinking about these other treatments. I have to say that the evidence that changing your diet will massively improve symptoms or reduce the growth of fibroids just isn't there. It might make a difference with some people if that's their individual experience, but I think people need to be realistic that, working really hard on changing your diet might not actually result in a huge benefit in your symptoms. I touched on it briefly, but there is a bit of evidence out there to suggest that the increase of fibroids occurring or growing does increase with obesity. So, having a normal BMI and a healthy, balanced diet is good advice for any health condition. So I think that's something that people can think about. And there also is a bit of evidence out there about vitamin D deficiency and that increasing the risk as well. So vitamin D deficiency is quite common in the UK because we don't get lots of sunshine. So it might be worth people thinking about supplementing their diet with vitamin D supplements as well. But the evidence about how much it actually improves things isn't really there at the moment, but would be really good to explore that further with future studies.
It's a very simple intervention, isn't it? So almost all of us are vitamin D deficient in this country, and don't be swayed by the good weather recently. It's only here transiently. So go along to your pharmacy and get 1,000 international units of vitamin D. Take it daily, or you can get weekly prescriptions as well. It really will make a big difference. If you take it as an oil-based capsule or as a mouth spray, it's absorbed better. And presumably, Marianne, it's because there's an anti-inflammatory effect, isn't there, of vitamin D, as well as the, if you like, the mineral content or
Yeah, exactly. We don't fully understand why there's this link between vitamin D deficiency and fibroids, but it is an area that people are actively researching. So yeah, it is very interesting and something quite simple that people can do themselves, and also brings other health benefits as well. Should just touch on, because it is really important actually in terms of diet and nutrition, that iron deficiency is hugely common.
My mind.
Yeah, so that's a really important thing to say. If you're experiencing periods that are on the heavier side, then, get your iron levels checked. If you're having any of these symptoms of tiredness, dizziness, palpitations, anything like that, just get a simple check of your iron levels, and think about supplementing your diet with iron tablets as well. They're not going to remove the fibroids or shrink them down, but they'll help you to feel a bit better day to day.
And the other thing I would say to our audience as well is that even if your hemoglobin, that's the oxygen carrying measure in our full blood count, even if your hemoglobin is normal, ask your doctor or your healthcare professional to check your serum ferritin levels. So this is your iron stores, because of course, when Rebecca was losing more blood every single month and thinking it was normal, what she was doing was depleting her iron stores. And so I see lots and lots of women who've got very, very low iron stores. They're absolutely exhausted. They tell me their hair is falling out, their nails are brittle, all sorts of other symptoms that Marianne has also mentioned. And it can be transformative to take iron supplements in the diet. They often give people upset tummies. So if that's the case, don't take it every day, but take it with a small glass of orange juice, which will increase the absorption by about 30%, and take it, say, 3 times a week or 4 times a week or whatever you can tolerate. And then if that doesn't work or you can't tolerate it at all, if your ferritin levels are low, think about getting referred to get an iron infusion, which would actually provide you with a whole year's worth of iron that you might not have got from your diet in a single infusion. So all sorts of things there. Now, would you like to tell us, Marianne, in the next 3 or 4 minutes, a little bit about your research? It's very unfair, isn't it, to ask a PhD student to be some of these things in 3 or 4 minutes. But I want the audience to have a taster of the excitement of what you're going to do for us in the future.
Absolutely. I mean, I think the first thing to say before I speak about my research project is that when it comes to fibroids, there's so much research that needs to be done. And Rebecca touched on that already. So, we still need to work out, why do some people develop fibroids and other people don't? And we know that they're more common if you've got a family history of having fibroids. Why is that? We know they're more common in Black women. And again, why is that? So there's lots that needs to be done. With my individual project that I'm doing, I'm trying to improve the whole journey that people currently experience. So as Rebecca has shared with us today, and I'm sure lots of other people on the call will have had their own experience of this, can take a really long time to get answers about symptoms and to get that diagnosis. Some people might need to be back and forth for multiple appointments, for example. And the other thing that Rebecca mentioned is that sometimes people don't realize that there's anything wrong at all because we normalize these symptoms. We normalize heavy bleeding and it's not obvious to us. And that's, a really common issue that a lot of people experience. So what I'm trying to do with my research is work out whether we can use samples of menstrual blood or menstrual fluid as something that we can test, so that we can give people answers right away to say there's signs in your sample that you're having heavier than normal periods and it could be due to fibroids. So what I'm doing at the moment is I've been collecting lots of menstrual blood samples from our really amazing research volunteers, and we've been analysing them in the lab, and I've been comparing the different results in these samples between women who have heavy periods and no fibroids and women who have heavy periods and fibroids. And all of this work, I'm going through all of this analysis at the moment, which is really exciting, is to try and work out, is there going to be some kind of indicator or something that we can test for in these samples that will allow us to get that information at a much earlier stage. And maybe even in the future, we could develop a test that women themselves could use at home and then take that to their GP and say, I've done this check, they're saying that I might have heavier periods and it looks like there might be fibroids. And I think that would be hugely beneficial for people to get those answers at a much earlier stage.
Lovely, thank you. I'm going to come to a few more of the questions. I've been trying to answer the questions in the questions I've been posing to our wonderful panelists. So don't think I'm ignoring you in the audience, but I would like to specifically talk now about what questions do you advise us to ask a consultant ahead of a myomectomy? What determines it being laparoscopic or open? Well, I think we touched on that earlier. Firstly, the size, because if your fibroids are right up to here, as Rebecca explained, almost up to her rib cage, then you just physically cannot get the laparoscopic instruments into the cavity and have enough purchase on all of those and enough control over things to use it. To use a laparoscope, that would have to be an open incision. Another alternative might be to shrink the fibroids down with some special hormones, which can only be used for a temporary period of time, but you could shrink them down in order to make them more receptive to a laparoscopic procedure, but that's not always possible. Marianne, do you want to make any comments, or Rebecca, when you about saying that? And then I want to come on to another question about whether, if you have an abdominal hysterectomy, whether it's possible to leave your cervix behind and why that might be something you want to do. So Marianne and then Rebecca.
So I think, yeah, I would just echo exactly what you said, Lesley, from your experience. You know, it can be really difficult to remove large fibroids using the really tiny incisions that are made through a keyhole procedure. And it is possible sometimes that people are recommended to start injections beforehand to help shrink down the size of the fibroids. I mentioned those briefly in the presentation. Those injections really significantly lower levels of estrogen and progesterone, and that can shrink the fibroids, but they do come with menopausal side effects. You know, they can bring on sudden onset of hot flushes, vaginal dryness, hair changes, all the things that people report around the menopause, but sometimes they are recommended to help with that procedure. I'm not sure, Rebecca, what your experience of that was, whether that was even an option for you or what they suggested.
Yeah, that as we said earlier, because of the size, open myomectomy. But one thing I do want to mention is I was told by my consultant and also by other women that I help support. Sometimes you can be told by a consultant, if you're going onto the NHS, you could be told that you'll have to have a vertical incision because of where the fibroids are located. But there has actually been instances where women have gone to get a second opinion on the private, and actually that consultant has actually said, I can actually do this as a horizontal incision. So sometimes it can depend on the skill set of the consultant. So if you're really worried that you don't want to have that vertical, incision, always get a second opinion. I would always recommend this. And at the minimum, you will at least get a peace of mind. So even if that second opinion actually coincides with the NHS saying that you do have to have a vertical, at least you got that second opinion and you explored those options. So that's something I would like, just to mention, because I have been told myself that, I could have had a vertical, but then I was told because of the skill experience of my consultant, he was able to do a vertical. I mean, do you come across that as well, Marianne, in the sense of the skill set of the consultant?
Yeah, I think it's certain centres maybe do more of these procedures, and it does often come down to the individual and the sort of discussion that individual has with the surgeon, looking at where the fibroids are and the size, and then making a decision together. But what I would say is that in any of these procedures, even keyhole procedures, if there's any complications that happen during the procedure with heavy blood loss, for example, or any complications like damage to the bladder or the bowel that unfortunately can happen, then, it is quite common then to have to convert, if there's complications, to what we call an open procedure and make those bigger cuts. So even if you start off thinking that it's going to be keyhole, just be aware that if there are any complications, then those incisions might have to be made. Yeah.
One of I just want to add as well, sorry, Lesley, is that when you do go in for open myomectomy, you do have to sign a disclaimer to say that if you do have heavy bleeding and they have to save your life, you may have to come out with a hysterectomy. So any woman that, is a very big decision to make. And I did know that because of the advanced stage of mine, I knew there was a high chance I may have come out with a hysterectomy. So you also have to prepare yourself mentally for that as well.
That's a really good point.
I would also add that's an important point to make, and I was going to say that it's important that you are suspicious, audience. If your surgeon doesn't warn you about potential complications, you may think that it's, you may think that it's great that they're not saying, oh, well, we might have to have an open one, but I'm afraid that is not the case. So taking out the fibroids is the easy bit. The problem is actually closing out the hole that the fibroid has left without damaging the uterus so much and actually stopping that bleeding. Because sometimes, as you heard, some of Rebecca's were 10 or 12 centimetres. That's a large hole in the uterine muscle that has to be closed over and thing. Now, I promised that I would say something about removal of cervix. So several women have explained that as they were menopausal or they were perimenopausal, they've been advised to have a hysterectomy and remove the ovaries and the tubes. I think that's possibly a good thing in terms of you're not then going to, if you're perimenopausal, you're not then going to need to have your ovary scanned. Remember, we now understand that ovarian cancer, which is one of the silent killers that women have to deal with, we now think that the origin of the cancer is actually from the fallopian tube and not the ovary. So the gynaecologists that I talk to now say, well, if a woman's got to have a total hysterectomy for fibroids and she would like to keep her ovaries, that's fine, but she should have the fallopian tubes removed as well. And then with regard to the cervix, I think this is a very individual surgeon's preference, but you can keep the cervix, remembering, of course, that some women say that that ensures that they don't have a total disruption to their sex life. Others say it doesn't matter at all, that having the cervix removed didn't change that at all. Of course, you do always remember that if you have the cervix, if you maintain your cervix, then you've got to carry on having cervical smears. And it may possibly increase your risks of getting a bit of prolapse later, but certainly it's a possibility that you can discuss. Now, Faye Ruddock has joined us. Faye, we're just in the last few moments. I'm so sorry that there's been a problem with you joining today, but I know that you are one of the patient public voices for women and the chair of the Caribbean and African Health Network, CAN, and you've worked very hard to address systemic inequalities in women's health. So I'll give you the last moment or two to just address the audience. There are lots and lots of people on this call, and just say, tell us a little bit about what you would advise them to do if they are Black or in the form of Caribbean or African, and what they could do to advocate for themselves.
Thank you so much, Dame Lesley Regan, and I do apologise not being able to join earlier. But yes, in terms of the Black and Asian community, particularly the Black community, there is, as you know, there's a huge disparity in terms of the numbers of people that tend to get it. And I know, probably working in this area, every other Black woman that I speak to has fibroids, and we know that how debilitating it can actually be. So we have started the APPG on Black health, which was registered earlier on this year, and we've taken fibroids to be the first priority because it's so problematic for our community. So what we are doing as well, we had a call for evidence, and we've had almost 400 plus people that have responded to that. And we can see already that because of the lack of evidence out there, we've got no evidence in the UK about the numbers, the data, but what we are trying to do is get information about people's experiences. And we know that people from our communities have a really poor experience. So what we're doing is we're going to be pulling together peer-to-peer support groups. We're going to be doing lots more research. And also we want to do a campaign as well, which is really focused on how do we bring attention to fibroids in the Black community, because we can see lots of work going on in different areas of women's health, even though it's not enough. We want to see more around the disparities in Black women as well, just because of the impact it actually has on them from a holistic perspective. So yes, we continue to do that work.
Lovely, thank you. Well, I'm sure that you can look up CAN and the network online. I have to now bring things to a bit of a close. I want to explain to everybody who's in the audience that by registering to come to this, it means that you will automatically be sent a copy of the recording. So to all of you who are working with women who you think or know of women, please share the recording with them, and then they can benefit from all of the evidence that you've heard about today. And now I have the very pleasant task of thanking our panelists, Dr. Faye Ruddock, Professor Faye Ruddock, Dr. Marianne Watters and Rebecca Brown. I think the audience are going to agree with me that they've done a fabulous job in keeping us up to date. I see that we've still got a very, very, very large number of people still on the call. So you've really retained everyone's interest right to the last second. And I'm going to have to log off now because otherwise I get into terrible trouble with the Wellbeing of Women team if we go over our hour. But lots of people saying brilliant, fantastic. Thank you for all the information. So helpful. Looking forward to watching the recording again and again. So really, really well done, ladies. And I'm sure that you're going to be on the must have them back again on the webinar to do some more about this really, really common problem and something that we've learned so much more about how we can better help women. And please, please, as a last plug, go onto the Wellbeing of Women website and use the period symptom checker and then become a friend of Wellbeing of Women and help us to carry on funding the research that's so needed to help girls and women have lives where they can get on with their life as opposed to being troubled by these problem periods or menopausal symptoms or whatever else. So thank you to everybody. Thank you to the Wellbeing of Women team for putting it together in their usual very efficient way. And I really do hope that we meet again soon. I can't really emphasize how many things are going across this chat feed at the moment. Masses and masses and masses of them. So a big clap to you and well done and thank you again. And I look forward to seeing you soon again. Bye-bye.